All right, good evening, folks. Welcome. Welcome, and thank you for coming to the Wisconsin Alzheimer's Disease Research Center's Fall Community Conversation, where we'll be focusing on the impact of social connections on brain health. I'm Dr. Art Walasek, this evening's host. I'm the Vice Chair for Education and Faculty Development in the Department of Psychiatry at UW. I am the co-core leader with Dr. Dorothy Edwards, whom you'll be hearing from soon, of the Outreach, Recruitment, and Engagement Core of the Wisconsin Alzheimer's Disease Research Center, and I lead the public health pillar at the Wisconsin Alzheimer's Institute. Tonight, we'll be hearing about the science behind social connection and why it's essential to our well-being and more. I want to take a moment to thank our event volunteers and our lead supporters, Vista West Senior Living, as well as the Wisconsin Registry for Alzheimer's Prevention, or RAP, and the Clarity Studies, who helped make this event possible. Their support assists us in bringing important education about Alzheimer's disease to our community. Before we get started, I do want to acknowledge that we respectfully acknowledge both the Middleton Performing Arts Center and the University of Wisconsin-Madison occupy ancestral Ho-Chunk lands, a place that our nation have called Tejope since time immemorial. In an 1832 treaty, the Ho-Chunk were forced to cede this territory. Decades of ethnic cleansing followed when both the federal and state government repeatedly but unsuccessfully sought to forcibly remove the Ho-Chunk from Wisconsin. This history of colonization informs our shared future of collaboration and innovation. Today, UW-Madison respects the inherent sovereignty of the Ho-Chunk Nation, along with the other 11 First Nations of Wisconsin. We encourage you to learn more at oursharedfuture.wisc.edu. I hope that you had some time to wander through our resource fair, which was generously co-sponsored by Dementia Friendly Middleton / West Madison. We want to thank our exhibitors for participating this evening and contributing to our community's health through their vital work. Okay, you should have all received a red welcome tote bag, so pull those out. We've got a bunch of goodies in there for you. I want you to make you aware specifically of a couple of different items. So really critically is an evaluation form. So it's a yellow piece of paper. Pull that out and please give us your feedback. We'll be collecting that at the end of the evening, and we really critically, we need your feedback. We base our programs on the feedback that we receive, and through your feedback, we can do a better job with our programs. If you're interested in participating in research, you'll find a brochure in your bag. Join the search for a solution. The brochure gives an overview of what we're currently working on at the Wisconsin Alzheimer's Disease Research Center. If you'd like extra brochures to share with friends and family, we'll have some on a table just outside this room for you to pick up on your way out. We will have some time to address audience questions after the presentation and panel discussion. Please write down your questions on the blank index card. You'll also find that in your red welcome bag. And then staff members will come by, collect these for the question and answer portion of the session. This event is being recorded, so if you want to relive this awesome memory, you'll be able to do so by watching it on our YouTube channel, and that information is on the back of the event program. And then finally, please take this opportunity to silence your phones and various other devices that might be shouting at you during the course of the evening. Thank you. All right, I want to start by introducing our first speaker for the evening, who is Dr. Sterling Johnson. Dr. Johnson is a faculty member in the Division of Geriatrics and Gerontology at UW-Madison's Department of Medicine and the Jean R. Finley Professor of Geriatrics and Dementia. He is the Associate Director and Biomarker Core Leader at the Wisconsin Alzheimer's Disease Research Center and the Associate Director of the Wisconsin Alzheimer's Institute. Dr. Johnson, a clinical neuropsychologist, leads the landmark study known as RAP, or the Wisconsin Registry for Alzheimer's Prevention, and is also a lead principal investigator for the ADRC Consortium for Clarity in ADRD, or Alzheimer's dementia and related dementias research through imaging. That's also known as the Clarity Study, which recently received the largest funding award from the National Institute of Health in the history of UW-Madison. So congratulations and welcome, Dr. Sterling Johnson.
Well, good evening, everybody. It's great to be here. I am delighted to just spend a minute or two with you and introduce you to the Alzheimer's Research Center. Many of you are aware of our center, and I just want to give you a rough overview of the center before we move on with the rest of our program. So let's go to the next slide. What's happened in our field this year is really quite remarkable. Last year at this event, we had a discussion about lecanemab and these new anti-amyloid drugs that the FDA has approved. Well, this year, the FDA has approved yet another drug. It's called donanemab, and it's up there. And what you're seeing in that chart are people who didn't receive the drug, having that flat line towards the top of the chart, and people who received the drug going very much down in terms of the amyloid load that's happening in their brain. So this is really an important breakthrough, these two drugs and the ones that are going to follow, in the fact that they remove amyloid plaques from the brain. The question that our field now has is, when is the right time to give these drugs? And how much hope and promise should we put in these drugs when we know that many people who come to us with symptoms have more than just amyloid plaques in their brain. They also have neurofibrillary tangles, the tau protein, and other things that may be happening in their brain. So we've got a major step in the right direction. We have reason for optimism and hope in this field. We're not completely where we want to be with treatment, and we still very much need your partnership and your support as we go forward. So let's go to the next slide. So our Alzheimer's Center is really trying to address care. It's trying to address biomarkers and more effective intervention, and we're looking at the biology of this disease. And we see here the state of affairs in our country and in our state. In Wisconsin alone, there's over 110,000 people who have dementia presumed due to Alzheimer's disease, and this is what we need to fix. Let's go to the next slide. Our center is one of 37 centers across the country, and we were just renewed in April of this year for another 5 years of funding, so that's just a really fantastic thing. We're excited about that. Let's go to the next slide. We, as a center, are really focused on the biology of this disease, and we partner very closely with the group on the right side of the screen here, the Wisconsin Alzheimer's Institute, who is very much charged with bringing research findings to the community, supporting physician education and community education as well. On the next slide, we'll see our two major cohorts throughout our AD program really center around the Wisconsin Alzheimer's Disease Research Center and the Wisconsin Registry for Alzheimer's Prevention. We give very similar batteries in many cases, very similar cognitive tests and measurements. And if we go to the next slide, we see that our participants, which is some of you in these studies, are all over the state of Wisconsin and then some, many to our south and in the borders, on the other side of the border in Minnesota and Michigan. We are, as we do our work, we are making discoveries on a weekly basis, if not faster. Let's go to the next slide. We are committed to doing research that is generalizable to all communities. And in particular tonight, we want to thank those of you who are from our African American community, from the indigenous communities that we serve. We're so thankful for your support and your volunteerism and generosity in being part of research, so that research can benefit you and your community and those who come after you. So thank you for all you do as research participants. The next principle I want to mention is sharing of data. We not only share research findings through our publications, but we share data, and we do it in a way that doesn't involve sharing your personal information, but we share data with qualified, talented scientists all over the world. And that's one of the major missions of the Alzheimer's Center. I guess I'll just say here that some of our major initiatives are around identifying the disease as early as we possibly can so that we can get people into the right treatments at the right time, and so that we can either prevent or slow down this disease as much as we possibly can. So let me stop there. We'll turn it over to the rest of the program tonight. I'm going to introduce Dr. Dorothy Edwards next. Dr. Edwards is a professor of kinesiology and medicine. She's the director of the Collaborative Center for Health Equity at the UW School of Medicine and Public Health. She's also the Outreach, Recruitment, and Engagement Core Leader of the Alzheimer's Research Center. Her research aims to support the development and implementation of more effective interventions for persons with cognitive loss and their families. So let's welcome Dr. Edwards to the stage for the rest of our program.
Thank you. May I have my first slide, please? That's the second one, but okay. So thank you. I'm going to put my glasses on my head so I can see because the light's shining in my eyes. But I'm here tonight to talk about social isolation and loneliness. And one might not think that the experience of loneliness or social isolation could affect not only your health overall, but your brain health in particular. And the issue of social isolation and loneliness has always been a problem. People studying the aging process and looking at people aging in place, for example, have been aware of the effects of social isolation and loneliness for quite a long time. But the COVID pandemic, as we all know, created terrible isolation. We were in our homes, we weren't out doing the things that we were normally doing, and the lingering effects of the pandemic, on top of the normal effects of social isolation and loneliness, have created a bit of a crisis. So may I have my next slide, please? So much of a crisis that the Surgeon General actually has written a comprehensive report about it. And Surgeon General Murthy says that, social loneliness affects our brains, our cardiovascular systems, almost every physiologic system in the body. And that there's mortality associated with loneliness and isolation. And so we really wanted to choose this as a topic tonight to explore. I get to do sort of the structured lecture, and then we have a great panel that's going to be really answering some questions. Then with the opportunity, I'll be collecting your questions from the audience. So next slide, please. So social isolation and loneliness in older people is really a significant health issue. Next slide, please. And those of us who are, I happen to be a psychologist, so we study the effects of isolation, loneliness, also looking at well-being. And we find that in the academic study of social isolation and loneliness, we look at structures, or the number and variety of relationships that somebody has, the function, the degree to which these relationships serve our particular needs, and then the quality, the positive and negative aspects of relationships and interactions. So remember, a long time ago, in the 1960s, David Reisman wrote a book called The Lonely Crowd. And there he said that society was moving to a place where individuals could be in large groups. And no matter how large the group was, if there wasn't good social interaction, if people didn't feel like they were connecting to each other, that caused problems. So this is not a new problem. It's been around for a long time, but we're beginning to actually look beyond the more social effects into the effects on brain and body health. Next slide, please. So social connections are really, really important, and I don't need to say that to all of you because you're here tonight. You're being connected with us. You give the opportunity for our center to connect with you, which is really important for us. And that relationships and interactions with family, friends, colleagues, and neighbors create a sense of social connection. And then I'm going to go back to the pandemic, when we were immediately forced to stop the things that we normally did. And I can tell you, in a university setting where we're in touch with people all day, every day, in classrooms, in meetings, we have meetings, we work over lunch, all of a sudden there was nothing. And while people were really productive, like the University of Wisconsin got more research money, I mean seriously, more research money in the 2 years after the pandemic, and we had more papers published, we found that people were really not happy. They don't like Zoom meetings. They were missing the conversations around the table, the opportunity to have lunch with a colleague and talk about a problem. And so we're still actually kind of getting back into the swing of things. But we know that this was true in other groups as well. So what we found was that this was always an ongoing problem, but the pandemic really broke those social connections, and we're seeing in the time after the pandemic that it's really hard to reestablish connections once they've been broken. Next slide, please. So, you know, I'm going to talk a little bit about one of our favorite topics, the social determinants of health. And this is actually one of the aspects of our center. We don't just look at brain and biology. You know, yes, we want your blood and we want your cerebrospinal fluid, and please, please come in for the imaging visits, because Dr. Johnson would be very unhappy if I didn't say that. But we're also measuring the effects of social determinants of health, and that is social isolation, it's the quality of contacts, it's the nature of the neighborhood in which we live, it's the experience of discrimination, which causes social distance. So we're looking at all these things and how they impact risk for dementia and Alzheimer's disease and other dementing illnesses. Next slide, please. So again, I have the technical presentation. So you can see that the components are social connections, and then there are the processes, which are sort of biological, psychological, and behavioral, and then the outcome is health. And all these things are working together. So we tend to think of brain-body relationships more in terms of physiology. But the very act of sitting in a room and learning something new and asking questions and having conversations is also affecting our biology and our physiology. Next slide, please. So I want to talk a little bit more about these pathways. So we can actually measure the effect of isolation on the gut microbiome, which our center also studies, on neuroendocrine and immune function being inflammatory processes. So people who are really lonely and isolated tend to have more inflammatory markers, which suggests that their bodies aren't functioning as well. It's associated with chronic diseases such as diabetes, arthritis, other problems, and we know that positive social connections actually reduce disease risk. So this is not just negative, this is positive. So those individuals who are satisfied with their social connections, and it's not so we look at the quality as well as the quantity. I happen to live with an introvert. He doesn't talk, he talks to the dog and not to me, because the dog doesn't talk back. Now, he was very involved. He was a professor at the university. He held a pretty high position in the research administration, and he retired. And he's really happy, not talking to anybody every day. And I couldn't possibly retire and be home with him, because I would be really in big trouble. So I work, he stays home, and he's happy, and I'm happy because I get to be in connection with a lot of people, but that's our different personalities. So for people who are introverts, there's no magic number. They don't have to have 10 friends or 20 friends. One friend, one contact is enough for that person. So it's highly individualized. Again, I don't want to make it think that more is better. For some of us, more is better, particularly those of us who really look for deep connections with many people, but for some people, that's just too much. He once told me that he was really glad when you could pay for gasoline at the pump, because he didn't have to say hello to the person at the cash register. And I thought, that's terrible. But it worked for him, right? So anyways, the next slide. So what is loneliness? So loneliness is really a complicated thing. It's not just, it's a feeling that comes from the emotional quality of interactions, the social qualities, and I can't see my own slides. And the sort of the existential feelings. So when we think about it, it's actually a very complex process, and that's what makes it interesting to study, but also more complicated. Next slide, please. I really want to call out sort of a misperception and a stereotype. So we know that loneliness and isolation affect Black and Indigenous elders significantly, but despite the high rates reported in these groups, it's often under-recognized because our societal assumption is that African Americans or Indigenous individuals live in multi-generational families. They tend to have a more collectivist approach to life, so there's more community around. And that stereotype is actually very harmful because it causes you not to look for the effects of loneliness in groups of individuals who may in fact have significant challenges. And I'm going to go back again to the COVID pandemic. The burden of COVID was substantially higher in Black and Indigenous communities. More people died, more people have long COVID, more people continue to feel the effects and continue to be infected. And so we haven't yet measured the effects, particularly in Indigenous Black communities, but we think that this is going to be an even bigger problem. So what are some of the signs of living with loneliness? Next slide, please. So what we know is that social isolation actually accelerates cognitive decline. So chronic loneliness and social isolation increases the risk of developing dementia by about 50% in older adults. That's a significant number. Even after controlling for demographics, like the age of a person, their education and health status. There was a study, a longitudinal study that followed older adults over 12 years and found that cognitive abilities declined 20% faster among those who reported being lonely. And so we know that more frequent social engagements with family and friends, doing cognitively stimulating activities in social settings is protective. And we're going to hear more about that with our panel after I finish speaking. Next slide, please. So how does social connectivity and loneliness affect the brain? It's very, very interesting. Next slide. So there are a series of imaging studies of loneliness and brain function. In fact, there are 41 different studies that I found with more than 16,000 participants. So thank you for volunteering. This is how big data happens, is because people take the time to volunteer for our studies. And what they found, they looked at all sorts of different imaging methods, so computer tomography or CT scans, fMRI scans, MRI scans, and PET scans, all of which we do in our center, and found that different areas of the brain were actually affected differentially, but affected in measurable ways. Next slide, please. So, for example, all these areas are really important to the development of Alzheimer's disease and other dementias. For example, loneliness was linked to changes in the hippocampus. That's where our memories are formed and our memories live. The prefrontal cortex is really important in terms of emotion and behavior. So that, again, in studies specifically of Alzheimer's disease, we found that there's higher amyloid burden in individuals who report social isolation and loneliness. Now, there may be other factors involved, but it's remarkable that even after controlling for all these other factors, we still see an effect. Next slide, please. So, how does this work? Well, first of all, social interactions, conversation, and challenging activities challenge the brain and promote sort of mental agility. Social engagement can help strengthen neural connections. People with the most social interactions experience the slowest rate of memory decline. And social engagement can help people, older adults, but all adults, experience a sense of purpose, satisfaction, and happiness. And we know that greater social interaction in midlife is associated with reduced risk in later life. Next slide, please. So how do we actually address this? Next slide. Oh, that's pretty smushed, but anyway. These are just different kinds of activities that the Surgeon General himself recommended that you can be socially engaged by reading because, it connects you in other worlds in other ways. Doing social activities, having a partner, volunteering. Pets are really important. Getting out and being physically active with others, playing cards, any of these things are cognitively stimulating, socially stimulating, and really, really help our brain function, but also make us happier and healthier. Next slide, please. So, I want to start with the Surgeon General and end with the Surgeon General. So the Surgeon General has actually created a national advisory strategy, and it's founded on these 6 pillars: strengthening social interaction, the infrastructure itself, enacting pro-connected policies, mobilizing the health sector so that people who are healthcare providers need to be very much aware of the effects of social isolation and loneliness and promote engagement. Really improving and supporting the digital environment. So when I talk about the fact that we get tired of Zoom meetings, there are some people, particularly in rural communities, where the ability to engage with people, with their computers is really, really important. AARP of Wisconsin, for example, there are about 755,000 members of AARP in Wisconsin, and they actually have a digital engagement program to help older adults in rural communities engage in social conversations and activities to promote engagement and loneliness, because they're aware of the effects of just geographic isolation, lack of transportation. Sometimes the fact that there are tremendous age differences in communities as younger people leave. So digital engagement is really good. Deepening the knowledge and cultivating cultural connections. In other words, really strengthening those cultural ties that keep us connected to our communities, our families, and others. And I'm going to end there. Thank you. And now it's my great pleasure to bring back my colleague, Dr. Art Wallachek, my co-core leader, who's going to take us through the rest of the evening.
Dr. Edwards, thank you very much. What a fantastic foundation for the rest of our event, which is going to involve our panel discussion and our Q&A. So I would like to welcome our three esteemed panelists. So as I call your name, I'll ask you to come on up and take a seat up on our stage. So first up, I'm delighted to introduce Dr. Andrea Gilmore-Bykowski. She is an associate professor in the Burby Walsh Department of Emergency Medicine at the School of Medicine and Public Health, where she also serves as associate vice chair for research. She serves as deputy director of the UW Center for Health Disparities Research and is a co-leader of the Wisconsin Alzheimer's Disease Research Center Care Research Corps. Her work focuses on identifying and characterizing episodes of paradoxical lucidity in people living with advanced Alzheimer's disease and related dementia. So welcome, Dr. Gilmore-Bykowski. Up next, I'd like to introduce Dr. David Rakel. He is chair of the UW Department of Family Medicine and Community Health. As a faculty member, he founded the Integrative Health Program, received the Gold Foundation's Leonard Toe Humanism in Medicine Award, and has worked with over 50 clinical systems within the Veterans Health Administration to make care more personalized, proactive, and patient-driven. Dr. Rakel has published 11 books, as well as much peer-reviewed research on the impact of mindfulness meditation and the therapeutic encounter. So welcome, Dr. Rakel. And finally, I'm delighted to welcome my colleague, Dr. Vani Sisehut. She is a psychologist at the William S. Middleton Memorial Veterans Hospital, an adjunct clinical faculty member at the UW School of Medicine and Public Health, and also maintains a private practice. Her extensive experience encompasses working with patients with chronic disease, terminal illness, and those in need of palliative and hospice care. She also supports individuals with multicultural issues, acculturation, racial identity, and intergenerational trauma and conflict. So welcome, Dr. Sisehut. Thank you so much for joining us. How y'all feeling? All right, great. Thumbs up. All excellent, great. Well, very good. So I just want to tell you a little bit about the format here. So when you all registered, you had an opportunity to submit questions, and so we've taken some of those questions and incorporated that into our discussion, and then we added, we sort of mixed in a few of our own questions as well. So I'll be directing some questions to each of our panelists, but we're also hoping to engage in some discussion. We'll do that for about the next 35 minutes or so, and then we'll pause, and then we'll live take questions from all of you in the audience. Remember, you've got those cards in the red tote bags where you can put your questions. So I'll go ahead and get started. Dave, the first question is for you. As we just heard, you founded the Integrative Health Program at UW. You've conducted research on integrative approaches in medicine, author of many writings on the topic, including a wonderful book, Integrative Medicine. Can you share with us how loneliness and isolation contribute to health problems?
Sure, it's a big topic, right? But if I could summarize, the goal of integrative medicine is salutogenic science, so salute, health, genesis, origins of health. So how do we put our science to keeping people healthy and out of the hospital with a perfect memory their whole life, and then we slide into home base and we die? We're all going to do it, but how do we really shorten that time between our health span and our lifespan? So I think integrative medicine really appreciates the interrelatedness of all things, and social isolation is, let's focus on the salutogenic approach. Social connection is such a positive thing that we can give each other to enhance our sense of resiliency and really stimulate those self-healing mechanisms that nature gave us. And, I think one of our best teachers is nature. So if we want to look at how we should do it, look, there's rarely a tree alone. And one of my favorite books is The Hidden Life of Trees, and it talks about the science of how they interact. So I think integrative medicine helps us really understand that unfortunately not yet, hopefully with the research from our center here in Wisconsin, we'll have a silver bullet, but we don't have one, so we need silver buckshot. So how do we use all these different opportunities, nutrition, social connection, exercise, learning new things, reducing toxicities? How do we stack the deck in favor of this really important organ system to work well?
Thank you so much. So much great stuff. Very vivid metaphors in there as well. And I love that idea of health span versus lifespan and kind of how to extend our health span as much as possible and limit that time between the two. So and then tying that to social connection as well. Appreciate that. And if either, Vani or Andrea, if you'd like to comment on that question or any others along the way, please go ahead.
I love that analogy about the tree. It's so true.
Yeah.
You don't see a tree alone.
Yeah.
You grow together. There's connection.
Well, Vani, I'll since you took a shot at that, I'll direct a question towards you. So in your work, you've seen people go through difficult times that can lead to loneliness. What are some of the warning signs that you've seen and maybe folks in the audience should be aware of that people that they know, that we know may need some help with making social connections?
Yeah, so older adults will experience a lot of stress and changes that may contribute to increased loneliness and social disconnection. So some losses to be aware of. So death of a spouse, death or loss of a relative or friends, change in living arrangements, so less likely to be living with other people, deteriorating physical health, so maybe not being able to drive anymore, losing your driver's license, so some loss of independence, impairment of mobility, impairment of vision and hearing, and reduced social activity. So if you see any of these signs, it's really important to ask more, to seek some resources. Resources are out there. So thinking of loneliness, that's the subjective feeling of being alone. So in my work with patients, I ask them directly, do you feel lonely? How often do you feel lonely? Do you feel isolated? So just getting a sense of how people feel is really important.
No, I love your last point. There was a paper that came out last year or so that just that one question of do you feel lonely or not is predictive of various health outcomes. And so I've tried to incorporate that into my initial evaluations of folks as well. Just that one simple question can open the door to lots of other questions and potential for linkage to resources.
Absolutely.
Yeah. Okay.
I'm going to take the offer to add. Also, if we are squinting, I cannot explain how bright it is up here. We want to be looking at you all, but it can't be understated. I really like that explanation, and as I'm a nurse, I don't know if we mentioned that, but something nurses think a lot about are transitions, and I think, lots of times we think about transitions as these major life anchors, but health is about dynamic transitions, and they can be environmental and contextual, and they can be individual, relationship-based. So I think just awareness about transitional states that we go through, and sometimes they're not always interpersonal. We get really fixated on, I don't know if it's because we're an individualistic society, as they say, you know, ourselves and our immediate connections. It could be something like, I'm relocating to be closer to my daughter and that person's family. That's a really big transition in your context. And other sources of support that maybe you utilize quite frequently, but haven't thought about how important it felt to feel safe going to your coffee shop and having this small dialogue with your favorite barista. Like, this is the good stuff of life. I mean, we're going back to the same coffee shops for a reason. It's not, you know, there's something to that. So even these environmental shifts can be things that a transition just introduces vulnerability and it introduces opportunity. And so I think those are other things that I think about a lot in my practice that seem, you know, maybe you're moving to a new, better apartment. Like, what are we leaving behind sometimes?
If I might build on that, because I think just opening with that question, it drops us in a little bit deeper. And how we ask those questions, I think, really matters. You know, in the clinical exam room, we have this computer, and it's almost like we're looking at the computer and we're doing clicks. Are you lonely? Click. And we don't even connect with this human being. And I think these meaningful connections are so important. And I think it's really one of the key nuggets of why loneliness is such a risk factor, because if we don't have a person, a human, to really go deeper into meaning in our lives, I mean, think of that question, are you lonely? Whoa. I mean, that opens up all sorts of opportunity for us to go a little bit deeper into that emotional meaning, which connects all these hormones and neurotransmitters that gets things flowing. And so anyway, I think how we ask that matters as well.
Well, and you know, as a busy clinician, I can envision, do I really want to ask that question? Like, what sort of Pandora's box are we getting into? But I think it's critically important, and it gets to really fundamental stuff. You know, Dorothy had one of her slides, kind of existential aspects of loneliness. I think that's a huge part of it. Like, why am I here? What purpose do I serve? And for many people, it's those connections. It's being a grandparent or a member of a religious community or other things that are very valuable to them interpersonally. And so, you know, on the one hand, it can be a lot of work unpacking that question. On the other hand, I think it's a gold mine for potentially helping folks out. Yeah, good. Andrea, you and I have worked together around the care of folks with people living with dementia, their caregivers. You brought up transition. Certainly people with dementia and their caregivers face lots of transitions. And your research has been on improving the lives of people living with dementia and caregivers. What are some special opportunities or challenges for caregivers with respect to addressing loneliness and isolation?
That's also a really big question, and I've really been thinking about, you know, I wanted to make sure that, like, we're talking about challenges, but that we also talk about opportunities. And I think I'm going to answer the question, but I'm going to take us down a meandering path, if we would. You know, we are very fixed. We're often deficit-oriented. This is also nurse talk. You know, we're focused on the things we're losing and the things we're lacking. And interestingly, when people finally started asking caregivers, care partners of people with dementia, you know, can you tell me about a moment of connection you've had? Can you tell me about something that's gone well? It turns out people identify many positive aspects of their caregiving experience. Is it really, really difficult? Do they like, you know, that this is happening? No, of course not. It's awful. But people identify things such as, you know, they've had interactions with their loved one or a proximity to them they never would have had. They never would have had this time, or it brought them closer to siblings, or they learned something about themselves they never would have learned. So with that, you know, it's also a shared experience, and I do think it offers, you know, opportunities to connect to others in that community of people that have been impacted in one way or another in their lives by all of the changes in memory and thinking that we might see someone experience if they live with dementia, and that's what we see day to day. You know, it's not a diagnostic label, it's how we can get through the afternoon, it's how we can have pleasant conversations, how we can spend time together. But I think the meaning of connection through that experience also morphs a little bit, right? You can find all these micro moments that are so meaningful in the face of sometimes the loss someone might experience. So I just wanted to make sure that I mentioned that, there is opportunity and there are positive aspects of caregiving. In terms of challenges, I think the biggest one really is it's time scarcity. So caregivers are often occupied, unfortunately sometimes it's a 24-hour gig. And when people are in that situation and their network, we often think about it not just as, do you have social connection that's enjoyable, but are you in a network where people check in on you? Do you have what we call looser ties? It could be the neighbor down the street that makes sure they stop and talk to you, when they're walking. Are you connected at all? So maintaining those close ties can get really difficult, and even the weaker, looser ties can start to fade away. So things that I think are really important are, I really liked these ideas about when can you look for sort of indicators that someone is maybe really getting isolated. And I think that a challenge can be, a lot of times it's with sleep disturbances that people experience. And when everybody isn't sleeping well, it becomes very difficult to do anything at all. And those are times when we start to think about someone getting into a crisis situation. They're maybe functioning on crisis. So I think those are the challenges we always want to get ahead of. So I love some of these ideas that were offered about how can you just be curious about, if there's someone in your neighborhood or someone are you able to get out for any amount of time during the week? And are we able to get that person some resources they can get a little bit of time? And sometimes that's the real ingredient we need. And even like 4 hours a week can just change somebody's life substantially and give them that chance.
Thank you. Cover a lot of territory there. Dave, Ani, any responses to that?
Well, I've worked with a lot of caregivers, and this is actually an experience that's very common. There are challenges. It's so difficult. It's one of the hardest jobs, being a caregiver. But they wouldn't change it. Having that opportunity, like you said, to spend with your parent or your spouse. So I do help. I help caregivers just process all those emotions and accept that this is part of the deal, and work through that. But again, finding resources to help with some of those issues, sleep or things like that. So I think if we can help them with that, I think caregiving itself, I think people really find meaningful.
Well, I want to amplify actually something all three of you have talked about, which is thinking about this from, you phrased it beautifully, Andrea, instead of a deficits-based, kind of a more positive approach, you use the word, I think, salutogenic, did I get that right? So kind of thinking about things that promote health. And even in this, preparing for this, we kind of went back and forth between referencing loneliness and isolation, which are negative things that people are missing, versus social connection as a more positive thing. So that's a tension that we have about how to reframe a lot of these things as either they're positives or things that we can do to help address the issues that folks have. So I appreciate all three of you kind of hitting on that point in different ways. In terms of additional resources, you should also have in your red bags some handouts or pamphlets from the National Institute on Aging, and there's a bunch of great ideas in there and kind of specific tips to help address and promote social connections. Okay, so Dorothy touched on this, so switching gears here a little bit. A big driver of some of the challenges we've had in this area was the pandemic and the isolation that went along with it. So Dave, I wonder what your thoughts are about how the COVID pandemic and its associated loneliness and stress may have contributed to health problems. And I'm referring to it in the past tense, but we still have COVID. There's a bunch of COVID, there's RSV, there's influenza, there's all kinds of things that continue to challenge our ability to stay connected with other people. So another easy, simple one sentence answer, I'm sure.
Well, I think Dorothy summarized it beautifully. And one of the mantras I love is meaning builds memory. So how do we bring meaning into people's lives? And I think COVID was, it isolated us and it blocked us off from meaning. And it changed our whole culture of how we communicate. And, most of communication through social connection is nonverbal. And sitting with someone with compassion and kindness is much better than you reciting how kind you are. You could never get that information more clear by just being that way. And then we had all these Zooms, and then some people don't even turn their camera on, so it's kind of like, hey, Andrea, how you doing? How does that make you feel when someone's doing that? So we create these barriers that are making us, number one, not have enough information. And when we don't have enough information, our default is I'm not good enough. And that's kind of what social isolation does. If I don't have enough information, I'm sitting in my room doing Zoom or even behind a screen, that self-doubt starts to play. And when that self-doubt starts to play, we start to perceive our world in a more negative light. And when that starts to happen, this whole cascade of neurochemicals have a negative pathogenic approach or result. Pathos, to suffer, disease of suffering. Salute, that's why we're focusing on the positive, is health. How do we facilitate health? So I think COVID was a beautiful thing that brought us to a new place of being. We'll never think of all the carbon we're saving doing Zoom calls instead of driving to meetings. But there's also tremendous risk in not doing in-person, face-to-face meetings, because there's something about this that we can't get through a screen. There's something about this.
Or the water cooler conversations, right? Or just those impromptu discussions that are actually really important too.
That was beautiful, and I want any other reflections on kind of the pandemic and kind of the impact that it had, either for you, Andrea, or Vani, what you saw in your work?
I guess, as we're thinking about caregivers and people that might be experiencing dementia, perhaps, I think it was, really illustrated for me in terms of what I would see clinically, thinking about just vulnerability. And caregivers are a really important sense of continuity, and there actually is legislation that's being passed this year to identify family caregivers of people living with dementia, sort of their ongoing care partners, as essential members of the care team, because what people were seeing in nursing homes, and perhaps you recall this, some of this from the news or major media, is they would see just rapid acceleration and decline when people who were living with dementia didn't have access to those visitors, and that may be, the one anchor they have. So it is, in a way, really puts a microscope on the physiologic impacts and all of the decline that was seen so rapidly in people. So I think, in a way, it brought us to a new place of policy in which it's been recognized that family caregivers are essential members of the care team because of the physiologic effects of loneliness.
So we got a lot of questions from folks who had registered around what about people who, for whatever reason, have difficulty leaving home. They have mobility issues, or they have difficulties with transportation, or other things that might get in the way. It's all well and good to talk about social connections, but what do you do in that context? And Bonnie, you and I know each other because you do this tremendous work through the VA and a home-based primary care team. You teach others about that work, and so you have this unique perspective coming to veterans who do have difficulties leaving the home. And so I'm curious what you've seen for folks what challenges are the folks who live alone or are unable to leave the home, what challenges they face, and what ideas do you have for promoting social connection among those folks?
Yeah. So I work on this team that serves older adults, and we really have this interdisciplinary approach to care. So with mobility, I really encourage just all disciplines being involved, meaning the patient working with OT, PT, PCP looks at medication to address maybe controlling pain, or depression that might be contributing some to mobility issues, to motivational issues. So just, again, a team approach. And then talking with my patients about just doing a little bit, like stretching can help, just a little bit of movement, and then, not having to go too far. Maybe sit out in your patio and say hi to the neighbors or dog walkers, your mail carrier. I mean, just those little conversations, those little micro connections actually are really important too. That can still be a part of our social life. So just getting a little bit of that connection is just really important. And I see it in my patients, just even those little things like that. It's really helpful.
I like the idea of just sitting out on the patio to meet the neighbors. It reminds me of a story I heard today, which was of a person and his son who were sitting out on their patio and watched as one of their neighbors fell into the pond. And so the son ran downstairs and got the guy out of the water. And that was the first time that they had met and had a nice conversation. So, opportunity may strike to form some new social connections in unexpected ways.
That reminds me of a study after 9/11 in New York, after the Twin Towers fell. All the medical students in all the medical schools in New York went to the emergency room because they thought there would be this tremendous rush for emergency care after 9/11. And for the first 2 or 3 weeks, nothing. Hardly anybody came in. And then about 3 or 4 weeks later, people started to come in with more musculoskeletal symptoms like tightness in the neck and other things. And James Pennebaker, who did this research at University of Texas, he hypothesized that initially people came together, similar to falling in the pond, right? People came together and they supported one another in their community, and the amount of suffering went down. Over time, the appropriateness of talking about 9/11 kind of went away, and people returned back into their apartments and their isolation, and then their suffering came out a different way, through headaches, through abdominal pain. Henry Maudsley, one of my favorite quotes of all time that I see this so often in primary care, is, "The sorrow that hath no vent in tears may make other organs weep." The sorrow that it's an old quote, as you can tell, that hath no vent in tears may make other organs weep. We see that so much in primary care. But if we have someone we can go and talk to who we can get that out so it doesn't go into our headache or abdominal pain or low back pain, that's such a healthy thing that we can do for one another through our kindness.
Just to riff on that a little bit, so Dave, of course, you direct a department filled with family medicine physicians who then interact with nurses and social workers and all sorts of other healthcare professionals. What's your sense about what we in healthcare can do to help promote social connections? We covered one thing, ask about loneliness, but what about any other thoughts about ways we as healthcare professionals can do a better job of promoting social connections?
Yeah, well, I'll get to that, but Bonnie and I were talking about the importance of interprofessional teams and that we'll never be able to train enough primary care clinicians. So we're really, first of all, want to create interprofessional teams, right? How do we maybe get someone who's depressed in to see Bonnie, the psychologist, before Dave, the physician, which is probably much more appropriate before we start to add medications on. We have a lot of resources in our clinics, like one is volunteer opportunities. And I don't think we've ever had a negative outcome unless it was a bad community of a volunteer opportunity. Because think about it, you're giving to something you believe in, you have a community, and you're giving of yourself to others. And it kind of goes along with that meaning builds memory. What's our meaning and what's our community that supports our meaning? And it kind of brings us into spirituality, if you will. Churches are a really healthy thing for a society. 20% of people go to church now. And I don't think people are going to start going to church, but why are churches so valuable for a society's health? You've got people who have meaning together, and they're supporting one another. And we need that, whether it's in a church or some other way, whether it's a meditation group or a book club or a wine group or a volunteer group. So I think any way we can promote that. And sometimes that'll be all we recommend. Hey, you've got all these conditions going on. I want you to go volunteer for this group that you really feel strongly about.
I want to add to, I didn't talk about technology, right? That role in technology. So if people have a hard time getting out of their house, that can be another avenue. I mean, there's limitations. I think Dave, Andrew, we talked about, but it's very valuable. I work with a lot of people in the rural Wisconsin, and technology is really important for them to stay connected. So I think this can be one part of a lot of different things that we can use, right, to help people stay connected. So, yeah.
I want to pivot just a little bit to highlight something Dorothea talked about, and also just to recognize the diversity of our state, the many different communities in our state. And Andrea, of course, you do research in this space. You do research on ensuring health equity in dementia care and research. What are some considerations for health equity when we think about experiences of loneliness or isolation, or, spinning it positively, promoting social connection?
I have so many thoughts swimming through my head. This is such a lovely conversation. I hope you all are enjoying some of these musings. I am going to answer that question, Art, but seeing as I have the mic, I do want to circle back. Just, we're having a little chit-chat. To thinking about that, when you're in your house, because I think there was something really important happen in this last conversation, which is we're alluding to, but not explicitly speaking about how, isolation and connection it's not just interpersonal, it's about belonging. And belonging is a complex construct, but there are ways we can create a sense of belonging for ourselves that don't involve an interpersonal connection. So maybe you're a knitter. Maybe you're a gardener. Maybe you go to the Sequoia Library, and that's your library. You're a part of a community. So it's ascribing a meaning to these places of connection. And, there may be individuals for whom they may have very few people in their network or very few people that they're connecting with, but they maybe have these other pockets. And that also is useful, and that could be a strategy, even if one were to be isolated at home. Maybe you play some online card game, for example, and that's a community of a thing that you do. You watch your local news, creating those ties for yourself so that you can identify that, I'm connected in these ways. So thinking about equity, this is a really big question. And one useful vantage point when we think about equity is to just think about sort of opportunities. And I think this is maybe the most simplistic way for me to tackle this question, but when people maybe are experiencing, we're all aging, which is good. It's beautiful and it's wonderful, and I mean that. And we will have different types of opportunity when we encounter health challenges. And what we know is that certain individuals, if they experience something like dementia, for example, maybe they don't get to the stage of that diagnosis until later. And I can't explain how hard it is to catch up on maybe 4 or 5 years of time in which you could have known what was going on, and you could have gotten set up, you could have managed finances, you could have made care decisions. People cannot make that time up. And what we know in our society is that there are just massive rifts. They walk often around sort of racial or ethnic lines, and a lot of that is very complex. It's not just economic, it's not just resource-based. These are many intersecting things that shape a different opportunity for some people than others. So in terms of when we think about equity and kind of a lens, that time scarcity issue, this is really well documented that, caregivers who are Black or African American or Indigenous or Latin or Latinx spend far more time in direct hands-on caregiving tasks, and that's kind of across the board. So they already have less time. They often also have other complex time demands. Many of them are also caregiving for other individuals, who may be in their families. And then the opportunities or resources that they have may not always be appropriate or a good fit, may not meet them, in places that they can access, for example. And so I think, when I think about opportunities, I always view this as how can we get everyone to a closer starting point? And I think that that's just an intrinsic challenge that we have to acknowledge. And I don't think what's useful for promoting equity and facilitating more social connections is to ask everyone to catch up. I just don't think that that helps. So I think recognizing that people may have even more limited capacity, and maybe it's things like scheduling calls, maybe they need different resources than what you might like them to need. And we did a study, a multi-site qualitative study, talking to dementia caregivers, community service providers, and we talked to, I think, maybe somewhere in between like 75, 78 people, something like that. And all I walked away with from that study was bigger fish to fry. And, I think that a part of this is we meet the most important needs first. And we were largely interviewing people who were in very under-resourced situations and under-resourced contexts from largely backgrounds that were less well represented in research. And I think it just tells us that what we need to do is meet the most immediate need and recognize that we can't ask people to do what someone who's had a different opportunity might be doing.
Wow, thank you. Yeah, indeed. Well, and you managed to cover two huge spaces there. One is I think what I gleaned from the first part of what you said is about, creating you can be in a position of creating relationships, like you mentioned, crafts and knitting and so on, or online activities, and then this really powerful way of framing health equity and thinking about the different places that people are starting from and meeting them where they're at. So really incredibly well done. I don't know if anyone else wants to riff on those ideas.
I don't want to go after that. No.
I'm just going to interpret that was organized, which is good because it felt very meandering. Sometimes it takes me a while to circle back.
Well, we're going to pivot here a little bit. We want to hear from you, and so as a reminder, look in those red tote bags that you got, and there are index cards and hopefully pens to write your questions down with, and we're going to have people circulating in the audience to collect those cards from you and then bring them on up, and it'll be a chance for you to engage a little bit more with our speakers here. While you're doing that, I just want to thank again Dr. Sterling Johnson for his wonderful introduction and leadership of our Alzheimer's-related activities. Dr. Edwards, who is one of our roving card collectors and will be helping organize for her terrific introduction to this topic and laying the framework for it. And of course, our outstanding panelists, Drs. Rakel, Gilmore-Bykowski, and Sisehut. So thank you all very much. You're not quite off the hook yet, though. We've got the audience Q&A. While I'm stalling for time to collect questions, I also want to remind you about the yellow evaluation forms that are in your tote bags. So please fill those out. We'd love to hear your feedback so that we can continue to offer you outstanding programs in the future. So get those questions submitted. While we're waiting for that, I think I'm just going to go ahead and forge ahead with some of our pre-planned questions, and then we'll move to the audience questions. Andrew, I want to go back to you, and Dave, you touched on this, about that beautiful story about kind of what happened after 9/11 and everyone anticipating all that emergency care and it not materializing till later. Andrew, do you have any thoughts about that? You have a leadership position in emergency medicine. You're interested in this intersection of aging and emergency encounters. Any thoughts about the relationship between loneliness and isolation and emergency care?
Yes. So, this isn't something that I think has been studied robustly in terms of have we associated whether people are isolated, and that specifically leads people who might be, having cognitive challenges to go to the emergency room. What I can say is that when we think about social connections, this really, it's about a buffer and it's about a protection zone. And, you know, the vulnerability that people might experience when they're isolated, when you get into trouble, it gets really, really hard to do those other things you can do that aren't go to this crisis point. So a lot of the times when we do see people who are on this emergency care pathway, which, you know, if we're talking about someone who has dementia, perhaps it's just a horrible place. It's not that people aren't doing their best work. It's not that those services can't be needed. It's not an appropriate therapeutic environment for someone who's experiencing cognitive change. And I think that that's well recognized. But when we think about what are the things that you could do, it could be just like calling someone else over so you could swap a different caregiver in and see if you can just, a lot of crises like self-resolve with time, but a lot of it is the caregiver really not having capacity to provide more care support and no failing of their own at all. And actually, very excitingly, tomorrow evening there will be a hearing in Dane County with the hopes of Dane County Crisis is trying to establish a mobile stabilization unit specifically focused for individuals who are living with dementia so that there would be an interdisciplinary team to go to that setting where that person is in their house and try to stabilize and save someone from, you know, going to receive emergency care. So can I say for sure, research tells us there's a link. I can tell you anecdotally from years of practice that, you know, when you have folks that can help you over a tough time, we can avoid a lot of crisis events.
Thank you. Yeah, I was involved in a project a few years ago where we were working with EMTs in the community on identifying people who are living alone, and we're often calling 911, a lot of emergency care, and so the idea was then the EMTs could help link people to some of the social services, basically identify people who might be at risk of loneliness and isolation in the community. So I like that link between our various community resources to identify people at risk and help them out. Yeah. Okay. Dr. Edwards, are you going to be asking us questions?
Yes.
All right, are you ready?
Okay, so first question is, and we have a lot of great questions. I'm not going to be able to do all of them, but what we did last year is that we took all the questions back to work and we grouped them together and put answers on our website. So we're not going to ignore you. I just don't have enough time to do all these great questions. But the first one is, how can we help destigmatize the diagnosis of dementia and support people to continue to be social after the diagnosis?
Okay. Well, I'll start us off. I know others will have ideas, and one aspect is what we're doing right now, and it's just talking about the fact that we all have brains and we're going to experience brain aging. And that can look a lot of ways, and for some of us that might look like developing dementia, and none of us know what path we're on. And we don't know what paths our spouses or our other loved ones are on, right? It's just the state of life for most people right now, if we were to draw a line around Dane County, for example. So I think just talking about brain health and brain aging, just like we talk about, you know, not wanting to experience falls and wanting to maintain balance and flexibility, even like dialogues, you know, with friends, with family members, that is a very tangible action that we can all take. And to normalize, I think a part of the question was, you know, maintain activities. And I know that we're in Middleton right now, and Middleton, I believe, is a dementia-friendly community, very proudly. But I think engaging with those efforts, if that's something you have capacity or inclination to do, is to help others understand the actions we can take to support people with dementia in being active participants in our society, and knowing that social participation is just huge in quality of life, and it's feasible. So I think just conversations are huge. We could all put it on our like New Year's resolution list for next year, for sure.
So I want to follow up on that. The World Health Organization, in the categorization of interventions for any kind of illness or disability, says that social participation is the end, the ultimate point of all intervention. It's to be able to engage in the meaningful activities that drive our lives. So.
Bonnie, did you want to say something about that?
I wanted to say that I think when there's changes, especially like changes in functioning, I think for me, and I encourage this to, when I work with patients, I really help them to prioritize and preserve existing social connections. Like, that's really important. But then I help people like accept kind of a new way to make social connections too. You may have, you have to adapt, right? There's adapting to this. And so that might mean like different social groups and, maybe a peer program or something. I mean, there's different things, but definitely preserving, prioritizing and preserving existing social connections. I really try to help people with that, as well as adapting.
In regards to preserving, what is preserved often with dementia is distant memory or early memory. And even though we can't always remember what we had for breakfast, boy, the question of, tell me about your childhood, really brings out the unique beauty of a human being that's there for a long time. So that regression therapy, I think it's called, is, how do we connect with that human and the stories that are there? And that's such an engaging thing that creates that meaningful connection with our colleagues and friends.
Great. Thank you all. Dorothy.
I'm going to put two questions together because they're related. The first part is, what are some strategies to help people who may not be ready or motivated to make social connection? And the second question is, how can we support individuals who suffer from social isolation and loneliness but are resistant to meeting people or trying new activities due to severe anxiety? So those kind of go together to me.
I hear motivational interviewing somewhere in that answer, so
Yes.
who wants to take a shot at that?
I'll take a shot at the first one. We can't change people, right? I always like to ask how many people in the room have someone they love, and I hope you all raise your hand. And how many in the room have tried to change that person? Everybody raises their hand. And how did that go for you? And the answer is terrible, right? You can't change humans. You can be with them. You can support them. But you're not going to change them. So I think in healthcare, the beauty of a salutogenic approach, or really focusing on the positive, is I can't fix your dementia, but I can walk with you and your family to a better place through it. And we're going to get there. And don't worry, I'll always be here with you. This team will always be here with you. Just that alone brings so much stress relief, I think. All right, now you guys can answer the second one.
Well, you said that really nicely, Dave. It does bring people comfort when we walk with them, So I'm thinking personally and also professionally, I'm there for people, just accepting them, and like you said, supporting them, just telling them about resources whenever they're ready. It just being there. There's something about just that presence. Your presence is very powerful.
Well, we run into this all the time in other clinical contexts, smoking. How do we help people quit smoking or other things, or help promote exercise or change their diets and so on. So, and I think there are some, I certainly agree, we can't change folks, but we can help sort of move them along, perhaps, that we use terms like contemplation. Well, I'm thinking about changing
There's
that.
pre-contemplation,
I forgot about it. Yeah, you can even be before that. I
Yeah.
forgot about that.
Yeah.
To
Contemplation, yep.
Thank you. I shouldn't be talking psychological terms in front of a psychologist, but
You're right. No, this is good.
But do you want to say a little more about, we don't have to get too
Yeah.
technical about it,
Yeah,
but just about, I'm reflecting on my training on like motivational interviewing, like some of those approaches,
Yeah.
if someone
No,
wanted
that's
to try to encourage someone to
Yeah.
make a new social
No,
connection.
that's exactly right. Just asking them about maybe what would look like when they're ready. What does that, what would that feel like? What would that look like? All that stuff. So just kind of like you said, supporting them, pushing them, not pushing, but supporting them along. And people will, they'll decide whenever they decide, but we can be there to encourage. So.
Yeah. This brings me to some of the work we did with the VA, is we changed the question of what do you want your health for? And when we ask that, what do you want your health for? It drops you into, all right. Or, you know yourself better than I do. What's the one thing you can do now that will improve your health 10 years from now? And maybe that's social connection, maybe it's improving nutrition, maybe it's starting a hobby. But then the patient or the person we're sitting with is in the driver's seat. And hopefully they will co-create the health plan based on what's important to them. So I think those deeper questions allow us to go somewhere together rather than projection.
Dorothy?
So we have a question here about what advice can you give for those people who are worried about showing their signs of dementia around friends and families and neighbors? They're embarrassed. So this really speaks to the stigma that many people feel. So what's the suggestion there to help people feel better connected?
That's a beautiful question. I have two ideas. One is you can ask somebody to do some of these things for you. And the second is to do some of these things yourself. And I think, if you've ever had a kind of conflict with someone when you know that there is a right path, there's always a strategy where you say, thank you for always supporting me and being understanding. And the person's like, gosh, I'd better support you and be understanding now. And I do think that there's an opportunity to, to tell people during those difficult conversations. The first thing I usually say is, I'm a little nervous about this conversation. This is really hard for me, and I want to thank you for always being supportive and understanding. And then, explaining some of your anxieties. The other thing is, we only have so much capacity that we can direct in so many different places. And that's a great thing that you could ask for some help. It's a really specific ask. If there's a longstanding neighbor you've been friends with and you're just not, sure if you can maintain that relationship, maybe there's a family member that you could say, if you could just help me by talking to the neighbor and letting them know that I'm really having some difficulties and I'm embarrassed to be around them, et cetera. And someone can bridge that for you. It doesn't have to be you going it alone. You could bring someone with you. And my other global thought is if you want to do anything, it's very useful to focus on one thing at a time. So maybe it's one relationship that you really want to maintain and you just want to start there. Or maybe it's one specific change that you want to make. It doesn't need to be I globally need to be more socially connected. It could just be, when I'm at a checkout line, I want to communicate to the person that's checking me out, with the groceries or whatever. It could just be one small change, and just do that one small thing. It's enough. And then move on to the next thing. Because I think we get this idea that we just need to do everything at once, and it's very overwhelming, especially with something of this nature. So those are my thoughts on that.
It's really hard to go after.
Do you want to give it a shot?
Yeah, I agree with, I encourage people to do kind of the same thing, focusing on one. I also help patients just work through the feelings of, again, having a cognitive impairment. That's really hard, those feelings, and just normalizing it, that this is a change, this is a loss, that, there's people are here to help you, you're not alone in this. So that's where I come from.
Thank you.
Yeah.
So we had a couple of questions about change, and in particular, moving. So questions about leaving a familiar community and moving for whatever reason to someplace else, to be closer to a son and daughter, or another move, perhaps, job or family takes you to another place. But this idea of being sort of dislocated as a aging individual, being dislocated from a place that you saw as being very supportive to a new place where you don't know very many people, and it's really hard at some points in life to establish the kind of social connections you had before. So how do you think people who are moving geographically away from what's familiar and supportive into a new place, what's the suggestion for helping restart and re-engage?
What's the research say? It takes 18 months to adapt to a new living environment, and I would think that patience is the number one thing, because generally with time, if people get outside their living situation, they slowly develop that social connection. You know, the beauty of having kids is that becomes your social connection. So as we get older and we don't have kids to use as an excuse, what is it? Maybe it's a spiritual connection, maybe it's a book club or another group that helps us adapt to that new environment.
Well, I think patience is a great idea. And also, if, things don't have to stop. Like, so perhaps you could do, I don't want to suggest Zoom calls. We've really had a lot of not great things to say about them. But this might be like the one instance where they would be really pleasant, or even remember like talking on the phone. I really miss talking on the phone. Sometimes I call my friends and no one wants to answer their cell phone anymore, and I'm like, I just want to talk to you, like we used to just answer the phone. But maybe you could schedule calls with people that are, in your current very familiar environment, and say, no, I'd love to have a regular call with you, even if it's just around the holidays twice a year. It's something you can look forward to. So there might be some relationships you want to maintain. And then I really like the idea of, if you want to go out and make connections, it sounds like maybe the question is getting reestablished. Be honest with yourself about things you actually like, and try to find communities that relate to things that you like or feel safe with. Whether like a book club is a great example, or if you have like some weird particular interest, find a community group that is into whatever that interest is, and that's an easy way to start because it's genuine. So I think that's why that's a nice starting place.
I think we talked earlier too about preserving existing social connections. So yes, you've transitioned to another place, but you can still keep those connections. So I agree with what Andrea is saying, whether it's a phone call, Zoom, whatever, FaceTime. I was trying to think about what that is. FaceTime. Anyway, yeah. So video calls, anything like that. And as you get adjusted to the new environment. And then, I think it's important to just go out, talk to the neighbors, talk to the person at the grocery store, just kind of get out, meet new people, things like that, but then still keeping some of these existing social connections.
This is an example from a different phase of life, but I recall moving to Wisconsin 20 years ago with 2 young kids, and one of my favorite things we love doing is just hop in the car on the weekend and go like, what is this place called Wisconsin? Why is there cheese everywhere? Why are they deep frying it? And, et cetera. So just like getting to know my new place. So I would sort of approach a move with curiosity, like, what is this place? What do people do here? What are the different sights to see, and so on. So that might be another way to kind of turn a potentially frightening experience into an opportunity for engagement and some curiosity about this new place.
So I'm going to switch gears, and I think we probably don't have time for very many other questions.
We're good.
We're good.
Yeah,
Okay,
about
great.
20 minutes. Yeah.
20 minutes. So I'm going to switch to caregiving because we had a number of caregiving questions. The first is the term caregiver or care partner the socially accepted term? I've heard both in use, but I'm not sure what the differences are.
That's a really good question. There's no right answer. I'm sorry. So I think largely, scientists and their nomenclature is so helpful. So care partner is very predominantly preferred and used in most countries that are not the U.S. And so that's a sort of a part of the distinction. Sometimes, like in the UK, they often just use carers more globally. So I think it's a matter of preference, you know, and sometimes we can just use more words, someone that's on this journey with you. Maybe they don't want to identify in that way, and they don't want to identify as a caregiver, and it can get really complex. We have very different relationships with people, and maybe that's not an identity that feels, for someone, even if they're doing caregiving tasks, maybe it doesn't feel like I want to say, you know, I'm my spouse's caregiver, I'm a spouse. So there are also lots of very different cultural differences in what people prefer and what feels kind of socially acceptable. And I think if you're wondering about in communication with other people what to say, like I always listen to how people describe themselves and then kind of run with that is another strategy.
Thank you. Any other comments? And here's a second caregiving question, and we'll go back to isolation. So what is the future of dementia caregiving in Wisconsin? How's that for a big question?
Well, I think it's a really big question. I mean, as with, you know, any other state, we anticipate that the number of individuals who are living with dementia will increase. And associated with that are that we know that the way that we manage dementia in this society is that largely the uncompensated labor of family and friends. So most likely it will increase concomitant with that increase in dementia cases. There are a couple of kind of policy things on the horizon. One is that some states are adopting some paid family leave policies, and those policies will be studied. We're not one of those states, but that's kind of something to think about, and that would involve, you know, some reimbursements. A lot of people that are caregiving are not able to maintain their occupational status. They may need to retire early, and this is an intergenerational impact when you really think about it. So that's one thing for us to think about, is whether the state of Wisconsin will have paid family leave benefits. And the other thing that I think we can just be mindful of is our state has something called dementia care specialists. So these are individuals that cover all of the counties of the state. There's not one per each county. Hopefully that program will continue to be maintained. It's a very unique program. So I think that there is awareness in our state and cohesion within that unit. I don't want to speak for them. My perception is that there's cohesion in that unit, and, you know, wanting to support caregivers and infuse best practices and, you know, develop all of these support groups, as there have been some changes in what is available through some big groups like the Alzheimer's Association kind of across the country. So I think we can expect more caregiving, but I'm cautiously optimistic that perhaps we'll have some policies that might change some of that experience for individuals.
I mean, I'd like to underscore the dementia care specialists and also our aging and disability resource centers. So the DCS, or dementia care specialists, are based at aging and disability resource centers, and every county either has one or is banded together with other counties. And this is a model that other states have come and explored. It's been an incredibly effective approach for getting the word out to people living with dementia, their caregivers, about resources that are available. So hopefully that infrastructure will help us in the future with caregiving.
I'm going to switch gears again, and I actually have a question for Dr. Carlson, who's sitting here. And that's what is the status or availability of blood tests for diagnosis of Alzheimer's disease?
It's a great question. So there are improvements in blood tests where we can now see if somebody has elevated levels of this amyloid protein that we know is related to Alzheimer's disease, and it reflects what's going on in a person's brain. So we're thrilled that we're able to get to that point. I'm not sure if they're FDA approved yet, so I don't know, Dr. Johnson, I don't think there's any that are FDA approved yet. So translating those from research into clinical practice is still underway, but I think it won't be too long until we see these type of blood tests in clinic. And while I have the microphone, actually, I want to ask our panelists a question. One thing that I see a lot of our patients and families struggle with is, they may have been, especially if they're a couple, they may have always been like the person living with dementia might have always been the one who initiated social events, going out, spending time with people. And then now, as they develop their dementia, they may not initiate that as much. And so care partners or caregivers a lot of times will say, I really struggle with, he doesn't want to do anything, he doesn't want to get out and do anything. And it might just be a matter of that they would enjoy it if they're out, but just getting them up to do something is a challenge. I don't know if you have thoughts on how to address that when there's that role reversal where the person who would initiate things isn't initiating, but they might still enjoy those activities. So thoughts on that?
I can get us started with that. I like, as a geriatrics lens person, I'm always on the start low and go slow, as just trial and error. Start with something small. If it's something that you think the person might, it sounds like the question is, how do we facilitate a level of social participation people might have previously had? So, trying something small, I think, is a great way to just be your own researcher and observe what happens. And does it seem useful, and do they have better sleep at night and say this was such a nice day? Those are the cues that was, a valued opportunity. And then I think there's the parallel of whether I often find, and I don't know if this is always true, that I also am partnered with an extroverted person, so I'm are all matches extroverts and introverts, and we're just suffering through life together? I don't know. So, if it's a question of this person also with those social connections, if you're missing out on those as well because they would have organized them, I think that idea of, maintaining things that feel protective to you is still a good thought. So that might be something to think about, is just trial and error.
You could introduce your partner to Dorothy's partner.
Yeah.
They'd sit together and not talk and feel very satisfied, right?
Well, and if I could build on that a little bit, we talked a little bit about, introverts versus extroverts. We all have personalities, right? And so those personalities have various characteristics, like how excited are we by new things or not, or how fearful are we of potentially dangerous things, and so on. And so those are things that have developed over decades and then play a role in all this, in the caregiving experience, in the experience of suffering from memory loss, in the experience of loss and social isolation, and then working on social connections. And so generally, there are some positive personality traits that we can build on to help with that situation and to help with promoting social connection as well.
So a lot of what we've talked about are relationships with adults, but we had a really interesting question about intergenerational activity and the role of children, that children are accepting, engaging. So what are your thoughts about the value of intergenerational activity and actually intentionally building intergenerational contacts?
Actually, Dave and I were just talking before this about why we both came back to the Midwest, and it was family. I was sharing with him about how important it was that my mother had helped care for my children, and just that connection that my children had with my mom, and just how important how meaningful that was for my mom, but also for the children, right? So there is something to be said about having an intergenerational household, or just having that relationship. It really benefits everyone. And I know that for my mom, she thrived off that. She had purpose, she had meaning, and then the children just loved being around her.
We had a group that got together. It was a think tank group, and we did World Cafe, where you go around and you try and solve problems together. And one of them was, how do we create a salutogenic community in Madison? And one of the ideas was creating intergenerational connections. So the older generation can give to the younger generation can give to the older generation. There's so much that each has to offer one another. But how do we get out of those silos of generations and really work together. So I think, it's just a natural idea that has to be organized.
So when my 4 children were small, their beloved grandmother had Alzheimer's disease, and she became very severely impaired. But she was always aware when they were there, and they were not afraid of being with her. It was fine to sit and hold her hand, or I have a very chatty son, and he would talk about, the Battle of Little Round Top. It didn't matter that she didn't understand what he was talking about. She would shake her head, and he would talk away. And I always felt that that was really good for my children, because they got to be with their grandmother and not to be afraid of the fact that she was changed. And she clearly was responsive. She didn't speak, but her eyes were open. She put her hand out. So I do think that even for people in the later stages of illness, that it's really, social contact is really, really important, but particularly contact from children, because they're not judgmental. They didn't matter when she was repeating things 100 times, it just didn't matter to them. So I do think that really promoting intergenerational activities and not being afraid to bring children into environments with people who are aging is really, really important. We'll switch gears again and ask a question about possible treatments for people in late stage dementia. So we're all excited about the new drugs, but those are really risk reduction early, and we still have many, many people in the later stages. So Cindy, hate to bring you up to the mic again, but I think this is an important question. What are we doing for people who may be more progressed?
It's a great question. So I think, just like Dave mentioned, I think a lot of times we think, well, what are the medicines that are going to help us function better later on in life? Whereas I think a lot of the things we've been talking about tonight, setting up a good structure, a good sleep schedule, really trying to keep people on, socially connected, investing in those things are really beneficial for people later on in the disease process. So there's always new studies coming out. So we have, studies for people with mild cognitive impairment and dementia that are testing new types of therapies. But again, like we're saying, it's not necessarily the silver bullet. It's going to be all these things that we can do, the social connectedness, good sleep, caregiver support, those things help people in that journey, helping work through the emotions and the loss. I think a lot of the things we've been talking about tonight are really key, especially later on in the disease stage as well. And they can make a big difference. I mean, it sounds, it's not just that we're giving up, it's just that we're finding more and more evidence that these types of things help, even if somebody has protein buildups of amyloid in their brain, that these social interactions, exercise, actually help kind of slow down the impact of that protein buildup on how functional someone is. So I think a lot of these things we're talking about are very valuable.
Thank you. Another question. We have a lot of great questions. This one is about the benefits of fasting. There's been a lot of stuff in the popular press about intermittent fasting and dietary restriction. Anybody willing to take that on?
I will. It's always an interest. Actually, there was a great New England Journal of Medicine evidence-based review on intermittent fasting. It's actually the oldest therapy on the planet. People have been fasting forever. And when we do fast, when we shift from having energy to not having energy, it not only mobilizes some of the extra energy found in our subcutaneous fat. And remember, this is why you don't want to eat a lot of fat on steak. Most all mammals store their toxins in their subcutaneous fat. So that's why sweating is such a good thing. And you don't want to eat it in other animals generally because it increases that. But what fasting also does is stimulate a brain-derived growth factor. So it enhances this neuroplasticity. And some of the exciting research is it might help reduce the risk of degenerative diseases of the brain. How do you do it? You need at least 12 hours. Ideal is 16 hours. So if someone's just getting started, I'll say start at 7 to 7, is one opportunity. So you eat from 7 a.m. to 7 p.m., and then you take a 12-hour fast after that. So most people can do that. You really want to avoid eating before bed, because when you eat before bed, it goes right to storage. And most of us, with all the access to nutrition, we don't want a lot of access to storage right before bed. But intermittent fasting it's been found to be beneficial in diabetes and neurodegenerative conditions. So I'm a fan. If you can do it, 16 hours is what the evidence shows has the best results.
Thank you. Another question for the practitioners in the group. A common discussion we have with senior friends and family concerns doctor's visits, specifically that we feel dismissed. Short visits, limited time, limited number of issues allowed to be addressed leaves us feeling disconnected and frustrated, or more importantly, devalued and isolated. However, this person has a family member who's received care at the VA, and the team-oriented approach makes them feel part of a group who cares in a very important way. So let's talk about doctor's visits and encounters with healthcare providers. And a shout out to the VA.
Yeah, no, first I want to just acknowledge the reality of that. The visits are brief, there are lots of issues to address, and I'm sorry for the person asking that question, having that experience, but we know that's reality. I would suggest sort of ways of preparing for visits that might help out with that, and that's kind of coming in very ready with clear questions or descriptions of problems. What is the exact thing that you'd like to have addressed? There are other ways of communicating. So in the UW system, there's MyChart. I'm not sure in the VA. The VA has an equivalent system as well.
My Healthy Vet.
So there's the visit, but then there's other ways of communicating as well. And sometimes that's a way where you can kind of get some additional thoughts out and additional questions and so on. There's phone calls. So there are other ways to engage besides that one visit. I like to teach folks, there's a skill that we use in interpersonal effectiveness called the Dear Man set of skills. So it's an acronym. D is describe, E is to express the concerns that you have. A is, I'm forgetting I shouldn't have brought up an acronym that I don't remember the details of. A is affirm, I think, and R is reinforce, like it's going to be a good outcome all around if you respond. So there could be some specific tips to help folks out with those admittedly very frustrating situations. Or others may have more articulate responses than mine.
I'm sorry. I mean, we have so much more demand for primary care than we have capacity to match. We try and give everybody the compassion and intention that every human deserves, and then there's always someone waiting. So what I love about being a primary care doctor is that I can break it into multiple visits. And we call that the primary care ICU. I will see you tomorrow. And if I can't do it today, we'll do it next week. So we focus on that one thing in this 25 minutes that we generally have is all. Actually, it's less than that. That's the whole time we have, and you have to get roomed and all that. But you're doing this in the home, which is a little bit different. You have a whole team that can go into the home.
Yeah, so Dave and I were talking about this earlier too, that the best model of care for older adults really is this interdisciplinary team. So I'm sorry, the person who asked this question, that you had that experience. Our team really understands that I think older adults are more complicated. There's a lot of concerns, and we do try to give that time, and going into the home kind of gives us a little bit more of that time than maybe in the clinic. And I really think that's such a special, I'm biased, special program to be able to provide that service in the home. So yeah, I mean, it makes a difference. And again, we're this whole team. So if there's dietary concerns, pharmacy, social work, we just have all the disciplines, and we're able to kind of keep a closer eye and kind of have more time. But I know not everybody has that program, but yeah, I think we all try to do the best we can.
I think these are all great ideas, and it's not okay. So we can just, I mean, I'm sure many of us have had these experiences. So I do think that, you know, because I'm a healthcare user, and then I also can see the other side of things as well. And a lot of the needs that we have or changes we experience are actually require multiple visits to address. Because sometimes you need data over multiple visits. So like if, you know, I have a concern about my memory, that is automatically, it's just gonna take us multiple, and it's not just like we can't address it in the time, it's we need to figure out what's going on, what information do we need, get information. Talk again, this was the information, what might we do? Okay, let's do that thing. Oh, we did that thing, talk again. So that's something to keep in mind, because it can change how, once you like kind of figure that out, it can change how you start to use care for some needs. Like, I want to have a visit about this need. Also, just, you know, a plug for like nurse visits are a thing for many clinics. Sometimes talking through changes or questions on a phone can get you that in between that you need as you're experiencing changes. So that's something else to think about as well.
It reminded me of a primary care hack, if you will. The best way to do it is get in for your appointment and then make a follow-up appointment at that time, because we can get you in if we schedule a follow-up appointment in 2 to 3 weeks. It's much harder to get in if you call just the scheduling center and say, I want an appointment. So once we're in, maybe it's going to take 3 or 4 visits. Make an appointment after each of those visits for a specified amount of time. So that's your primary care hack for access.
Yeah, and I'm sure Art's like, I don't know where we are with time, but
No, I love how
really
activated we all are by
phrase,
this question.
You know,
this is great.
yeah, there's just a lot to unpack here. You know, sometimes we do need to bring a care partner with us. So like, you know, if I've had a procedure that's something where it's like, I really would feel safer if I had this person with me, and I want you to treat them as though they're involved. You know, don't do something with me without them there. Thank you. And then, so just know that's something that you can request always, and really important words for us all to learn. I am really concerned about, like, you know, really saying that I'm really concerned about X. I'm really worried about this. And also, if something's impacting your functioning, letting people know the why, because we don't experience, like, that's the high level. That's not how you experience life. It's like, well, on Tuesday I did this, and then on Thursday this happened, and then the next week that happened. So I'm wondering about this, and then I was thinking about that. And getting to that high level statement can really help, I think, with just some of clarifying, and people should be able to listen to the long story, but making it really clear what your concern is, and if it's impacting you, letting people know, like, I'm not able to, you know, function the way I need to and to do the things I need to do if this is how my health is, and just making that really clear, and feeling empowered. Those are great, fair things to say, for sure.
Thank you all. That really got us all going, that last question. So thank you. I want to thank all the members of our audience for this wonderful engagement, these great questions that you had for us. I want to especially thank our terrific 3 panelists, Dave, Andrea, Vani. Thank you so much for joining us today. Thank you, Dorothy, for stepping up and helping us with the Q&A and your wonderful presentation as well. And I'll just say a few closing words. So thanks again for attending tonight's event. The Wisconsin Alzheimer's Disease Research Center provides this annual event as a way to give back to the community and our research participants. We want you to know what's happening in the field of Alzheimer's research here in Wisconsin and across the country. And I want to report that we're optimistic. Research is advancing both in the areas of treatment and prevention, as you heard about. And thank you to Dr. Carlson for stepping in and helping us answer some of those questions. These advancements are all thanks to our dedicated research participants who attend study visits, center events, and give us important feedback on the work that we do. Please stay involved and in touch with our center, volunteer for our studies, attend our events, listen to our amazing Dementia Matters podcast by Dr. Nate Chin, and reach out to us in other ways so that you can get involved. And as a reminder, this is recorded, so if you didn't catch everything, you want to go back and watch it again, it's going to be on our YouTube channel. Thank you all. Good night. See you next year.